Lumbar puncture, also known as spinal tap, looks scary and potentially dangerous to doctors who don't have a lot of experience with it. What if I hit a blood vessel and cause bleeding? What if I hit the spinal cord or a major nerve? What if my patient's intracranial pressure is too high and my spinal tap ends up killing them? These fears often lead to a delay in performing a spinal tap, unnecessary tests in preparation for the spinal tap, and most importantly, all of this leads to a delay in treatment, which, in the case of central nervous system infections, can be disastrous. So, let's see when you should postpone a spinal tap or avoid it altogether, and when it's safe and actually recommended to do it immediately so that you can take a sample of the cerebrospinal fluid and determine whether or not there are signs of inflammation or infection. The most common site for a spinal tap is the intervertebral space between L3 and L4 or L4 and L5. The easiest way to find the space between L4 and L5 is to draw an imaginary line between the patient's iliac crests. The place where that line intersects with the spine is the place between L4 and L5. That's your spot. If you don't succeed in obtaining CSF at that site, it's perfectly safe to go one space above or below. This is because the spinal cord ends at the level of L1, maybe L2 in adults, so there is absolutely no way you will hit it when inserting the needle in L3, L4 or below. So that's one less thing to worry about. What about bleeding? Isn't it risky to insert a needle into someone's spine? Many times, when doing a lumbar puncture, you will nick a small vessel and get a few drops of blood in the CSF or even pure blood. But don't get alarmed. Even if it's pure blood, just remove the needle and try again. You may want to use a fresh needle to make sure that the blood hasn't already clotted in the first one. If you get pure blood and it's not clearing up, most of the time it means you hit a venous plexus because you went too lateral. Don't worry, the bleeding will stop on its own in a few seconds and nothing will happen. On your second attempt, try going exactly through the midline. Now, if your patient is at risk of bleeding, now that's a different story, then you will not perform a spinal tap in the first place. People whose platelets are below 40 or INR above 1.4 are at risk. You may already have lab results available, but if not, at least check your patient's skin and mucous membranes before doing a spinal tap. If you see petechiae or larger signs of bleeding, postpone the spinal tap until you see the platelet count and coagulation studies. Also, be aware of patients who take anticoagulants. I always point out that nowadays it's not just warfarin anymore. There are many oral anticoagulants and antiplatelet medications with strange brand names, and you may not know them all. So, when you learn that your patient is taking some kind of medication you are not familiar with, look it up and make sure that it's not an anticoagulant or an antiplatelet drug. Of course, this is especially common in patients with coronary disease, atrial fibrillation, or a history of any kind of thrombosis or vascular occlusion. This is crucial because with some anticoagulants, you might need to postpone a spinal tap for 24 to 72 hours depending on the type and the dose of anticoagulant, and after antiplatelet drugs, you might have to wait for more than 5 days to make sure that the risk of bleeding has decreased, at least according to the guidelines. Now, my personal opinion, and I'm not alone in this, is that the fear of antiplatelet therapy is a bit exaggerated, and that too much caution in that regard may preclude a crucial diagnostic procedure, which is spinal tap, and delay life-saving treatment, especially with severe bacterial infections like bacterial meningitis or another life-threatening central nervous system infection. Clinically significant spinal hematoma is extremely rare, even in patients who take antiplatelet medications. Many experts are aware of this, and there are studies to back it up, but for now, guidelines and recommendations from expert societies still err on the side of caution, and it's best to follow the official recommendations, especially if you don't have a lot of experience with spinal tap. In summary, check for overt signs of bleeding, check your patient's medications, and if clinical signs suggest an increased risk of bleeding, check the platelets and coagulation studies. Okay, so increased risk of bleeding is the first contraindication. Then, of course, if your patient is in shock and hemodynamically unstable, you're not going to insert a needle in their spine. The priority is to stabilize them first, and then you can plan such invasive procedures. Also, If the skin in the area where you intend to insert the needle is infected, you are not going to do a spinal tap. This is common sense. It's the same if you suspect an epidural abscess right there in the lumbar area. You will not stick a needle through a structure that is filled with bacteria and introduce these bacteria into the central nervous system and the cerebrospinal fluid, right? I don't think I need to explain this one any further. So, bleeding, shock, any local infection, these are all common sense contraindications. But now we come to the tricky part where most mistakes are made in practice. In every textbook on earth, you are going to find that signs of increased intracranial pressure are a contraindication for spinal tap. Because if the pressure in the cranium is too high and you remove some of the CSF from the spinal canal, this might increase the pressure gradient between the skull and the spinal canal, thus causing the brain to shift and be pressed downward against the skull. This is called cerebral herniation and could lead to coma and even death. This is what we all learn in medical school. I think every medical student and doctor who has ever come across this concept will never ever forget it. It makes sense, it's easy to remember, and it couldn't be more dramatic. But is it true? Let's break this down. What could cause increased intracranial pressure? Any kind of mass lesion such as a tumor, massive intracranial hemorrhage, a large stroke with subsequent edema, or even an abscess with edema. Most abscesses have a very impressive zone of edema around them that is many times larger than the abscess itself. And any of these processes, depending on location, can obstruct the circulation of the cerebrospinal fluid, leading to the buildup of the CSF in the intracranial space, in other words, obstructive hydrocephalus. Such focal lesions, including abscesses, tumors, and focal infections, are more common in severely immunocompromised patients. Now that we know what can cause increased intracranial pressure, what kind of symptoms and signs should lead us to suspect that the patient's intracranial pressure really is abnormally increased? Well, a focal lesion like a stroke, a tumor, or abscess will most likely lead to a focal deficit or a complete disarray of the affected part of the brain. In other words, the patient might present with a new onset motor deficit, dysphagia, or a new onset seizure. Any of that should prompt you to look for a focal lesion. In practice, this will mean an urgent non-contrast CT scan before deciding about spinal tap. Also, if your patient is immunocompromised and you suspect a central nervous system infection, you will do a CT scan regardless of whether or not there are any clinical signs of focal abnormalities, simply because we know that focal lesions are so common in immunocompromised patients. In the literature, you will also find that if your patient has papal edema, this is a sign of increased intracranial pressure because the pressure causes the optic nerve to swell, and this is visible with fundoscopic exam. That is, if you can perform it. Most clinicians can't, so let's skip this one. As you can see, there are plenty of other signs to focus on. What is crucial is that if the intracranial pressure is high enough, it will press the brain against the skull, and the areas in the brainstem that control consciousness are among the first to be affected. This is why you will see in the literature that altered mental status is an important sign of increased intracranial pressure and should prompt imaging before spinal tap. And now we come to the part that I have a problem with. According to so many textbooks, articles, and published recommendations, altered mental status, decreased consciousness, or whatever you want to call it, is an indication for a CT scan. But this, I'm afraid, is a half-truth, and sometimes a half-truth is more dangerous than an outright lie. A crucial detail that is often missed is that a severely depressed level of consciousness is an indication for a CT scan. Severely depressed. This means Glasgow Coma Score 12 or below. Some guidelines will say 10 or below. So, stupor, almost coma, not just mild disorientation or drowsiness. And this detail is crucial because remember, most patients with a severe central nervous system infection will not have a perfect Glasgow Coma Score of 15. They will at least be a little bit drowsy or disoriented, something. They will not be fully alert, awake, and jumping around. An altered mental status is part of the standard clinical presentation of all kinds of encephalitis and meningitis, and in itself, it certainly does not require urgent imaging before spinal tap. Please remember this because this is a problem that plagues emergency departments all over the world. Glasgow Coma Score 14, quick, a CT scan, a headache and a fever with no neurological abnormalities whatsoever, CT scan regardless. This overblown fear in the end harms patients because it delays appropriate treatment. I always repeat that bacterial meningitis is as urgent as stroke. Any delay in treatment leads to a worse outcome. Period. If there are no clear contraindications for spinal tap, the ones that pretty much the entire world agrees on, you can safely perform a spinal tap and nothing will happen to your patient. But I know that if you don't have a lot of experience or your boss makes you do a CT scan before you even think of touching a needle every single time, you will do it. So pay attention to this final point. If you suspect bacterial meningitis, but you feel that you need to do a CT scan before a spinal tap for whatever reason, justified or not, just take 2 sets of blood cultures immediately and start empiric therapy for bacterial meningitis immediately. That's it. All guidelines and all experts on this planet will agree on this. Just keep things simple. If these indications and contraindications for a CT scan seem like a bit much, make your life easier and start treatment right away if you suspect a central nervous system infection. Then you have all the time in the world to do the CT scan or whatever else you want. If you suspect bacterial meningitis, the number 1 priority is to start treatment as soon as possible. If you've made it this far, I'm guessing this is something you have seen in practice. In that case, take a look at my free and paid courses on the most severe infections in the emergency department. I designed a quick, straight-to-the-point course about choosing the right empiric therapy for sepsis. This is something that guidelines often lack or don't explain in full, but for practicing clinicians, this is the central question, isn't it? How to choose the right antibiotics, even when you are not sure what is the source of sepsis. I also explained the treatment of meningitis in greater detail. In a couple of hours, you will master all you need and you'll be able to remember it when it matters most, even at 3 a.m. in a busy emergency department. The links are in the description. Good luck and take care.